So here we are in the anchor position of today with our last formal session before the reception for the Q&A component of our block on resuscitation. We certainly had a wonderful presentation from Dr. Cheskes on the state of the technology talk for ventilation to kind of frame everything, kind of drilled into a lot of different topics with the panel discussion. And during the chat, a lot of interesting threads came up as well. Some of which I like to carry into this part of our conversation. One of those was on teaching compliance, and there was some concerns expressed about being able to teach compliance effectively. John, could you maybe comment on that issue?
You know, it's an interesting that someone brought it up, excuse me, because it is very hard to teach. You know, some of the simulators, a few of them, especially the high fidelity ones, have the ability to restrict the lung compliance in the simulator. So when they're squeezing the bag, they can feel the compliance and they can understand what it feels like. But not everyone has high fidelity simulators. So you say, well, you know, what do I do to teach it? You know, there are ways to put simple things like expansion valves on the end of an ambu bag. Doesn't even need to be attached to anything, but you know, a gauge that shows how much pressure they're putting on. Simple things like that to allow them. What's the feel? I'm holding the bag. I got my little pinky up. You know, we're trying to teach them not to use a full hand squeeze. What is that supposed to feel like when I make that squeeze? What's the resistance supposed to feel like? But you know, the other thing that we have a lot of trouble keeping the flow on in education is the how rapid they're supposed to be squeezing the bag, and the feel for and the understanding of the number of ventilations compared to the volume. So that restrictiveness when you're squeezing the bag, but also, am I breathing for this patient in the proper speed? So volume versus rate is, the two of them are just as important. And teaching both of those, you can teach rate easily. You don't need a mannequin for that. So you know, yes, high fidelity mannequins help with that. And if you have any of the major all of the high fidelity mannequins actually have an ability to make resistance. You have to go in and manipulate the software a little bit, but you can do the resistance.
Yeah, so Bill Toon has some comments about this. He has an issue with how well they reflect the human airway, and it has a concern about it reflecting poor technique with the example he shows about the neck not articulating properly or at, I guess, the junction of the shoulders, but also made the comment about those pressures are very high when you block the valve. So I think there are different perspectives on this, different approaches, but how might you respond to Bill's comments, John?
Well, I mean, he has a point. You know, if you look at some of the head mannequins, they're not anatomically correct. We are starting to see more and more anatomical corrections in the medium to high fidelity simulators, especially the ones that are moving towards more realistic components in the skins and in they're using less plastic and more silicone kind of thing, so they get the better manipulation. But he has a point. If you pull out, I won't name any brand, but you pull out any of the older head only intubation mannequins, they're nowhere near anatomically correct because they can't be because of the plastics. So the more supple you can get when you're looking at simulators, the more supple the neck is and the more supple the shoulders are, the better off you're going to be. So it's one thing, you know, to look at when you're looking for airway trainers or you're looking at high fidelity mannequins. How much movement can I get in the neck side to side? How much movement can I get forward and back? And how soft is it? Not to mention the fact that how many adjustments internally does it allow with the tongue, with the teeth, with the airway itself? Can you restrict the airway itself? Those types of things. So Bill has a good point. There are a lot of airway mannequins out there that are not really good anatomically.
Well, and I think it comes down to the focus, because you may have a mannequin that focuses on one particular task well, but doesn't necessarily do all of them.
Exactly.
So it's just like using a milk jug for teaching chest compressions. It doesn't do a lot of things, but at least it gets the idea across about getting your shoulders over center, locking your elbows, and using your torso to do compressions rather than your arms. And so for that particular task, it does it, but not necessarily all mannequins for all things. So we have another comment. I'm going to throw this up on here. Another kind of improvisational approach. They take the old recessive baby mannequins, drill a hole in the neck, and try to get it accomplished that way. Isn't that what we do in EMS? Is we adapt and improvise?
Certainly do.
Dr. Cheskes, any thoughts about how you've approached trying to teach considerations of compliance in ventilation, particularly with kids?
Yeah, to be honest with you, it was great listening to that Q&A. I love listening to Joe Hawley get his input on stuff. I find Joe's phenomenal on the ventilation side. I think I have nothing innovative other than this new ventilation feedback that we're looking at, because I think that to me is going to be the game changer, being able to actually visualize it on the monitor, your tidal volume on rate and rate. I think that's going to be huge. I think other than continuous practice, I really have no magic solution for ventilation and knowing how much tidal volume you're getting. Particularly the PEDS group it's all practice as far as I'm concerned. Yeah,
I agree. And our thoughts with Dr. Holly and all the folks in South Florida at the building collapse. That's where Joe's deployed right now. Wasn't able to join us today.
Yeah.
So Dr. Toon has another comment. It really kind of makes the point about the whole idea of flight simulators with the immersive environment as well as the mechanical interactions you have is certainly ideal. And that's kind of the other end of the spectrum from what I talked about just a moment ago, where you have a particular simulator, mannequin tool focusing on individual parts of the whole task versus integrating them all together. And so just different elements of the training, kind of like, when you do disaster training, you'll do a tabletop exercise to understand the choreography of the major elements of a disaster management scene, which is very different than the, hands-on exercise with the simulated, crash of the vehicle, the aircraft, whatever the case may be, and you bring all the pieces together. So certainly valid points there. And
he makes a good point. There are simulators, immersion simulators that have haptic gloves that the student can put on, and virtual reality goggles you can put on that increases the sensitivity, especially the haptic gloves, and feeling what your hands are doing and what you should be feeling. The problem is they're extremely expensive and they're one-on-one education. So the opportunities to use those are rare. They're certainly better than most of the things we're using, but we don't see them as much on the medical side as we should. They're used quite a bit on the industrial side, and they're starting to move into healthcare. And as the price comes down, I think we'll start seeing services begin to look at those. But those that have the haptic results, meaning that there's sensation when you touch and when you move, they're very expensive. They're great to use. They're a lot of fun to use, and the students will love using them once we start it. It's just a lot of services don't have them right now.
Yeah, absolutely. So, some of the other things that come to mind with ventilation is we're talking more about ventilation now because we're finally getting some instrumentation that can inform our practice. And Dr. Cheskes, I think you'd probably agree with this statement. We've known that ventilation is important all along, but we just simply had no way to measure it in the heat of the battle, if you will, in real time. Certainly in the laboratory, we've been able to do it. Very early on in my career, I worked in a resuscitation laboratory, and we had pneumatacs and respiratory mode and blood mode mass spectrometers. I had 16 channels of data that I had to crunch through an Apple II computer onto hand wire wrapped RAM boards and stuff. We were instrumented, but I couldn't put any of that in an ambulance.
Yeah. There's no question. I think this is going to be the next sort of frontier in terms of resuscitation science, in terms of figuring out ventilation. Like when we look at the HA guidelines, they're not really based on strong evidence. They're because we don't have that ability to measure it during a resuscitation. Now we're starting to develop that, and really, I think we're going to really understand the impact ventilation has. We've been so focused on the compression piece, which I think is great. I think we focused a ton on the airway piece, which has given us a wide variety of differing results. And I think that has even thrown the question about which airway is best up there. But to me, very little hard and strong quality evidence in the ventilation piece. And I think that's going to be a very, very important segment as more services become involved with ventilation feedback, or just measuring ventilation, never mind feedback, just measuring it. I think we're going to really be surprised at the impact, because I really feel that based on our experience and what we've seen initially with ventilation feedback, most paramedics will just have no clue in terms of the amount of tidal volume they're doing, how quickly they're ventilating. I think they're getting better at it, but the tidal volume piece, I think, is a real important piece. So, hey, listen, I think that's going to be a big frontier for us moving forward. I think one thing that I would add, it was very interesting to listen to the panel discussion about the mechanical ventilation piece during resuscitation, as opposed to what most of us here in North America do, being using a BVM, using a supraglottic endotracheal tube hooked up to a BVM. That was interesting. I find that was very interesting, and how a mechanical ventilation, for the most part, I think in North America, is used for transport as opposed to in a resuscitation. So I thought that was a very interesting thing. I wonder if some of the others may comment on that in their experiences. I thought that was interesting to listen to.
Tom, any thoughts about that?
No, I mean, I think everyone's been really spot on with the conversations today. I've always been more of a low-tech guy from the standpoint, like we used to practice perishock pause with couch cushions in the day room at the fire station just to practice that choreography. Yeah. And I went the first 15 years of my career not knowing how to really use a BVM. So even though maybe current technology isn't ideal from the standpoint of actual compliance, just learning the rate and how to deliver princess ventilations was really eye-opening for me. And one of the things I worry about is, like, if we, depending on where we're measuring the airflow, just because air is passing through a particular point doesn't mean it's going into the lungs. Mm-hmm. So, you're on scene sometimes and you see someone's cheeks fluttering, air leaking out the side of the mask, the person squeezing the bag. Now, granted, this is why they need to understand the compliance piece, but I really, really am a big fan of the continuous waveform capnography, even if it's just between the mask and the bag and you're just ventilating someone with a BVM. I think we have to just verify that we are getting air in and we're getting CO2 out. Is very helpful. But even with the instrumented mannequins that we use, they may not be perfect, but if you bring a degree of seriousness to training, I think that trumps high fidelity. Mm-hmm. Because if you got a bunch of guys screwing around with a high fidelity mannequin, that's not good enough. I would rather bring guys and gals that are very serious about their job, that are there to learn, that want to do a good job, regardless of what the mannequin is. I think they tend to have a better experience.
Absolutely. A mannequin is an education tool. It's not the end all. It really is about how well the students are taught, how well the instructor uses it. It's a tool, and nothing substitutes for the real thing. I mean, there's no doubt. We just have to get as close as we possibly can. And repetitiveness. The more we repeat the training, the more we continually monitor that training, continually assess how they're doing in the field, the better off our resuscitation skills are going to be. It isn't something we can teach once every 2 years. It's got to be consistent. It's got to be constant, and it has to be monitored.
And Bill Toon makes the point about, we really need to see and work with real patients, and absolutely. But that's, to me, kind of gets back to the parallels with flight simulation. You think back on, the Miracle on the Hudson, where Sully Sullenberger, lands the airplane on the river and everyone survives. it's because there was an opportunity with simulation to train on that. You didn't have thank goodness we don't have lots of real world opportunities to have those sorts of disasters. So having the ability to train for those rare events, those unusual events, and make our whole range of muscle memories a little bit broader for those circumstances, I think is one of the great things about simulation. But like we've talked about before, there are certain elements of it, whether it's couch cushions at a fire station on Hilton Head Island to look at certain things, or bleach bottles teaching compression, the basics of compression technique. The other thing that kind of strikes me, though, is this really illustrates the essential synergy and partnerships that's necessary between suppliers and us as clinicians. Is our ability to intervene on our patients has largely been driven by the technology that's available to us. When, it's kind of dating my career a little bit, but I remember when the recording mannequins first came out. Yeah. Prior to that, it was, just, somebody watching you and saying, yeah, okay, you got the basic idea. That's and, then there was this particular emergency physician from St. Petersburg, Florida, that I went to my first ACLS class with, and he ran the Station 1 with the scenarios, and it was the basic CPR one, and he brings his ECG calipers, and he's on that graph paper, and he really understood that basic CPR was really important, but a lot of people made fun of him because it wasn't about the drugs and all the rest of the stuff that was then the big vogue, if you will, back in the mid to late 70s. Retrospect, proves that particular physician right with his emphasis on basic CPR technique. But my point is that when we had instrumentation to measure and give feedback on rate, more attention was focused on rate. When we got instrumentation to give us information about depth and recoil, et cetera, lo and behold, now we have a chance to improve it. And we're seeing that now with ventilation. So, that's one of the reasons why I wanted to do this type of conference is I think oftentimes in more academic conferences, the suppliers, because they have a commercial interest in things, are kind of set off to the side. And I think we need to embrace more of a partnership relationship with our suppliers and have them help us get the technology we need. So with that in mind, we've got now this technology that's starting to appear with ventilation volume and obviously the rate that goes with it. Do we need a pressure channel on this as well? We've talked about volume. We've talked about rate. Is pressure important enough to include in the instrumentation package? What do you think, Dr. Cheskes?
Yeah, no, I think it would be. No, I think it would. Listen, anything is helpful. So anything that gives you a parameter that's measurable is going to be helpful and is going to cause some adjustment. So, rate, volume, pressure is great. I think Tom hit it on the head, though, and I neglected to mention it initially, is the end tidal. Do you know what I mean? I think that end tidal CO2 monitoring in the context of all this. So it's not just seeing a number on the monitor that gives you volume. What's your end tidal CO2? What's your waveform? Understand, do I have a good seal? Is that an end tidal that I can trust? Is that a vital volume that I can trust? So there's a little bit, it's going to be to me a little bit more than just the measuring of volume and rate. It's going to be the whole combination of them that gives you an idea of, am I making a good ventilation? So I think the more we have available to us to guide the paramedics, the better off they're going to be, no question. But they need to understand the totality. It's not just one number, not just two numbers, it's going to be all, and the end tidal is a very big piece of it. So listen, I think now for most high functioning systems, end tidal CO2 is standard and the understanding of the importance is standard. Some of these new parameters are clearly not standard yet, and we'll need to see how they fill in and how they interact to actually have an impact on outcomes. So I think one of the things we're going to look at is, hey, does this ventilation feedback improve you from where you were before? So look at a monitor on, monitor off, do you get an improvement? But then at the end of the day, the big question is going to be an outcome question. Does it impact outcomes? I remember when we first started, CPR Quality Works, there were plenty of naysayers who did not believe that high quality CPR was going to make a difference. Yet lo and behold, as more agencies performed high quality CPR and numbers started going up, everyone said, holy shit, we better get on this high quality CPR train. I guarantee you the ventilation train is going to be the same. And it's just beginning. I think Entitle gave us a little glimpse. I think adding these other parameters are going to help us get a more complete picture of how ventilation impacts outcomes and more importantly, how it impacts performance. And I think we're going to be in for an eye-opening. From what I've seen so far, I think we're going to be teaching a lot of people a lot of new things. And doing things to get better. So yeah, I think it's the whole package, and I like to I agree again with Tom. Like you got to keep it simple. I'm not the big high tech. So when I first started this, there was no high tech, and so try to keep it as simple as possible. Makes it the teaching as easy as possible as well. So great comments by everyone on the panel today.
I'm going to bring Justin up a little bit. And Justin, can you comment a little bit about this high-tech versus low-tech issue as well? Because I think you have a perspective on this.
Yeah, so the big thing for us in our system is trying to get the number of paramedics that we have through the one teaching hospital in our region that's also trying to move every nurse and baby doc through the exact same high-quality sim. And unfortunately, as EMS providers, even if you have a very involved, very respected medical director, we're still going to be at the bottom of the line for that schedule, which is going to be Sunday nights, Monday nights. It's going to be probably not the best for our people in trying to get them through. And there was a comment in the conversations over on the side earlier that said, let me pull it up real quick because I love this back and forth. Bill says, let's stop looking for a shortcut to educate EMS providers. Let's put the time in to develop competent EMS providers. That's great, and it's going to be real quick, to try to implement. But if we don't have a good depth in our continuing EMS cadre, maybe they're all over with the new hires. We do need to look for some tech shortcuts to kind of play with a new toy or a new skill or something like that. But nothing beats, as we've all agreed, nothing beats actually getting out there and doing patient care with a competent preceptor. There's a place for high fidelity simulation. There's a place for VR and AR. We just haven't found it yet, in my opinion.
Yeah, and I don't want to take away from tomorrow's session that John will be leading, where we're actually going to focus on training. So let me bring the discussion a little bit more back to ventilation itself rather than the teaching of simulation. And Dr. Cheskes, if you could comment on what you might see as the utility, we're talking about this whole monitoring package. Do you see any utility for oximetry as part of this? Because ultimately we're trying to deliver oxygen. Obviously, the peripheral monitoring site at the tip of a finger or an earlobe, there's too much vasoconstriction peripherally. We're not getting any signal there during resuscitation. But what about a more centrally placed electrode, whether that's somewhere on the neck or the mucosa? Or now we're seeing the introduction of this cerebral oxygen monitoring technology. Could you comment a little bit about that, and if that would have any influence on ventilation, or is there too much lag time?
No, listen. Now, Mick, you're getting into you want to win $1 million today. Give me an answer to this question.
Okay.
This is the Nobel Prize of resuscitation. How do we measure oxygenation in a patient who is in cardiac arrest? So many have tried. Many have lost lots of money in this, in terms of trying to figure out the technology to do it. So listen, the closest we're getting, I think NIRS is close, so NIRS infrared spectroscopy. But again, differentiating scalp flow from cerebral flow has been a huge issue. And we Ian Drennan, who spoke, did a little bit of feasibility work with NIRS, and the machine was just too big for our ambulance. Like it was clumsy. And we found medics could put it on. How we could rely on the readings, very difficult. So yeah, understanding oxygenation in a low flow state would be fantastic. I just don't think we have something super that's there yet from my knowledge. Maybe others have something, but I'm unaware of something that does it well enough to actually be incorporated in a resuscitation. So clearly, if we were able to, it would have a huge impact. We use surrogates, right? Right now, we use end-tidal CO2. You look at pulses that we can feel. We use a surrogate of what we think is adequate perfusion when we retain it, but we really don't have something that can measure it. And many, like I said, this is something that many are working on. Few have been successful, to my knowledge.
And you know, to kind of button this whole idea up with the oxygenation monitoring, there's been, you know, discussion about oxygen toxicity and you know, using too much oxygen. That's usually been presented more in the context of STEMI management, perhaps a lesser extent to stroke because we're dealing with focal ischemias there. But are these at all concerns with high performance CPR and this improved blood flow with hyperoxygenation?
I think if you're really doing high performance CPR, no, it's not going to be an issue because you're going to be controlling your ventilations. And so I would say, you know, if you really boil down high performance CPR to its bare essence, it's rate, depth, recoiled ventilation, and perishock pause, and doing all those things at the expert level. So I think if you're truly not overventilating and you're controlling your tidal volumes, then you're not going to experience that problem. During post-resuscitation care, maybe, I suppose,
yeah,
you could, or once the patient's intubated, someone could, with ROSC, if you turn around and someone started overventilating. But no, I would say part of the bedrock definition of high-performance CPR is that you're avoiding that.
Yeah, and it's you know, hyperoxygenation perhaps more than hyperventilation per se. And there's other technologies out there too that you know, I think kind of fell by the wayside a long time, but now that we have better instrumentation in some of these sorts of things, I'm wondering if they'll ever make a comeback, like high frequency jet ventilation. We're oscillating the airway and getting mixtures with ventilation rates of 200 per minute, but extremely low tidal volumes. So, you know, and what impact might that have on the, you know, changes in intrathoracic pressure is going to be almost negligible. So a lot of stuff we still don't know about resuscitation.
That's why we keep doing it, Mick.
Absolutely. All right. So excellent. We're going to go ahead and wrap up this session. Thanks, everybody, for coming along on the ride today while we've talked about AEDs and ventilation technologies and how they fit into our respective practices. We're going to go ahead and end, and I would invite everybody to stick around with us and hang out a little bit in the lounge. Please say hello to our suppliers. Stop by the booth, even if it's just to say hello, and thank them for being here. Thank you for being here as well, and we're going to go ahead and end the session now. Thanks, everybody.